Welcome back. I'm Jason Andrade from Vancouver, Canada, and we'll continue on with our US focus for rhythm interventions online. For session 8, the focus will be on maximizing single operator case sufficiency with deep sedation, concomitant ablation with ice-guided left atrial appendage closure. I'm delighted to welcome our panelists for this session, Dr. Rodney Horton from Austin, and we welcome back Dr. Devi Nair, course director. I'm going to first hand over to our case presenter, Dr. Doshi from the Pacific Heart Institute, Santa Monica, to take us through the case.
Thank you, Jason. Thank you, Devi, and the meeting organizers for, again, the kind invitation. I'll be speaking today on concomitant ablation with ice-guided LAA closure and our technique of really single operator with deep sedation without the need for endotracheal intubation or GA. These are my relevant disclosures. So, in the next 15 minutes, I'm going to speak briefly on the practice patterns that we're seeing here in the U.S. and why some of that, especially with the announcement yesterday, as you think about CMS approving outpatient ambulatory surgery centers for catheter ablation, while it may not relate to doing concomitant appendage closure, clearly the trend is moving in that direction, and how we're going to address that growth and still maintain cost effectiveness and allow the procedures to still remain enjoyable. And this is where concomitant procedures are becoming more relevant. As many of you are aware, concomitant ablation with appendage closure now represents 25% of the appendage closure cases being done in the US, of which 2/3 have been done by electrophysiologists, and that number will likely grow in terms of percentage. In terms of the labeling, the reason why this is growing is the labeling has changed. The US FDA labeling currently for concomitant ablation is specifically for the Watchman Flex and Flex Pro device. The label was expanded in July of this year. And if you read the labeling, it's very interesting. So following catheter ablation for non-valvular atrial fibrillation, whether you do this concomitantly or sequentially within 3 months, which was really based on the option trial, and you're using this class of device, the Watchman Flex or Flex Pro family, what's interesting is that it says the devices are indicated, and it talks about, to reduce the risk of AF, something consistent, reduce the risk of thromboembolism, I should say, but it's in patients that are suitable for anticoagulation versus the indication of standalone appendage closures, patients who have an appropriate rationale to seek an alternative. This is the actual labeling now. And I think the reason why there's an uptake, honestly, because there is Medicare reimbursement. Again, patients need to have indications for both, so not just one or the other, but we're also starting to see private payers who are starting to cover this. And so why, is that right for your patient? Is it ideally, if you think about it, for the patient who will also require LAAC and the one that you're ablating, that may be the right choice. But I think it's important that if you're going to have this discussion, if you're thinking about concomitant, it's important that you have the discussion with the patient about long-term OACs before the ablation and not wait till after, and then the patient realizes I'm going to need to be on long-term OAC, and then they want to move forward with a second procedure. So I think the most key part here is that the physician should be highly experienced in both procedures, not just learning one or the other, but be good at both independently before they take on the concomitant procedure. So let's see, next slide here. Could we advance my slide for me? Okay, so the question though is why deep sedation with ablation? I think when we've transitioned over, for example, away from general anesthesia, from appendage closure, and started doing deep sedation and even conscious sedation, we realized what a dramatic improvement in room turnover time, but also what a dramatic improvement in patient recovery from the procedure. So if you can do the procedure without intubation, regardless of whether you have an anesthesiologist or using propofol, that seemed to make a huge difference in case efficiency in terms of room turnover and also patient recovery time, allowing and facilitating same-day discharge. Now, the sedation is based on propofol. So the difference is that if you're doing deep sedation with an anesthesiologist and you're using propofol, there's still a dramatic difference versus general anesthesia, even though you have an anesthesiologist, because when you're doing propofol-based sedation and you don't need a paralytic, specifically related to the type of ablation, then that facilitates, all the things we talked about. And why is there a difference? There are some differences in the ablation technology. Not all technology is equivalent in terms of patient stimulation. So what you're going to see when you look at generally monopolar versus bipolar, bipolar tends to be more localized. It makes sense. It's bipolar between electrodes. And when you're monopolar, you may actually see some things that necessitate paralytics. So here you're going to see in the next video, as this video will play on the left, you'll see, let's see, can you play that video on the left there? What you'll see is when this person's getting monopolar ablation, you'll start seeing the chest start to move as the paralytic started to wear off, and the chest would start jumping. There, you'll see it here, and you'll see the patient start to bounce. And this is just when the paralytic was still in effect, but it was just very, very light. Okay, if there was no paralytic, I would not be able to do this kind of case under deep sedation without a paralytic, which would necessitate intubation. Now, after we increase the paralytic dose, you can see the patient is not moving. And it's not just unique to every monopolar technologies. There are some monopolar technologies that don't necessitate or don't cause as much skeletal muscle stimulation. So ideally, you want to use a technology that will minimize the actual muscle fasciculations, hence allowing you to use propofol. And I think the other important thing is we recognize that people want to map. And so if you're going to map these cases, it's much easier and less issue when you have an integrated mapping system, because as the catheter tends to move, you'll be able to localize it during the procedure, and there's less chance of system error necessitating you to remap the whole chamber again and switch the catheters out because there are errors in matrix or ACL when the chest moves if the patient starts to cough because they're not paralyzed. And then in the presence of all that, how do we maintain cost effectiveness, right? Hospital administrators still believe that the disposable cost of the PFA catheters increase, therefore the cost per procedure will increase. Our goal was to decrease catheter and technology waste and only use necessary items. And we want to minimize HD mapping catheters if we can and use kind of an all-in-one approach to also conserve cost. So we know that EPs prefer 3D mapping, but can we map without intubation? Can we map without a costly high-density catheter? And do we even need a CS catheter? Ultimately, do we even need a second imager? If we're talking about concomitant, do we need an imaging physician? And then the question is, should the patient have pre-procedural imaging so at least you know what you're getting into, and we can discuss all that. So in terms of our access, we typically minimize access. We have 2 right femoral venous access sheaths. One is a 9 French sheath through which we put an 8 French ice, and we're able to draw back for ACTs. And the second is a transeptal sheath, which can then be exchanged for an ablation sheath, or you can try an all-in-one approach. The ice will go immediately to the left atrium as soon as you've done the transeptal and you cross over with the ice. So you can pre-image the appendage prior to consideration for LAA closure, because you want to get the measurements before there's any changes potentially from edema and whatnot. And then once, since there's no availability of a concomitant sheath, we do have to switch for an LAA sheath, and we essentially universally use deflectable sheaths because your transeptal puncture may not be in the most ideal location because you're trying to balance the need for location for ablation. Okay, next slide. All right, so let's talk about this case here. So this is an 80-year-old Japanese female, and I bring up the nationality because we know that Asian patients, especially those that are from Japan and China, tend to have much larger appendages than we see here on the West. And then this patient essentially has an elevated risk score. She had a TIA. If you can advance my slides for me, had a TIA and was referred for AF ablation, symptomatic AF ablation. And then essentially in the process of discussing catheter ablation with her, she's a very active 80-year-old, you'll find out later that this patient, although referred for ablation, has frequent nosebleeds and has to stop her OAC due to epistaxis and has a lot of orthostatic hypotension. So although the patient was referred for AF ablation, we had certain options in terms of what we can do. Obviously, the options of antiarrhythmic drugs are always there, but in today's day and age, someone like this, we'd obviously think about catheter ablation. And then at that point, we wonder whether we keep them on chronic oral anticoagulation or refer them for LAA closure, which it was discussed with. And even though she wasn't referred for concomitant, it was the appropriate thing to do for this patient. So let's take a look at this video here. This is just going to be 5 minutes. We're just going to talk about kind of the pre-planning. So right now, I'm just doing pre-imaging with my ICE catheter, kind of looking at the heart before I go transeptal. This patient has not been pre-screened. She's been anticoagulated. I wouldn't necessarily recommend that for routine, but I just evaluate briefly the appendage, get an idea of the anatomy. At the same time, I want to just assess the pulmonary vein since I am going to go over to the left side. You see, it's more of a common ostium with early bifurcation into the upper and lower veins, which you see below. And then we'll rotate around to verify kind of the right-sided venous structure that you see here. But I think the most important thing before we start any part of the procedure is to assess for any baseline pericardial fluid, because if you don't check, you're not going to know what was really there before, and then you might get a little nervous afterward if there was some fluid here. So here you're going to see we're going to do a final look at the appendage, but then really focus on checking for pericardial effusion. And typically, it's clocking the catheter, going posterior, and going rightward. And when you do that, you'll see a nice three-chamber view from the atrium. Right. So what you notice is, look, this patient has a baseline effusion. It's good to know this before I did any transeptal or any kind of ablation or appendage closure, just so I can compare that to. If I hadn't checked this before, I think we would have all gotten a little bit nervous in terms of what we would see after. So now we move to the transeptal for the concomitant cases here. And so you see, my technique is to pull this RF wire sheath down with the wire intact so as not to traumatize the atrium as I'm pulling down. As you start getting bigger sheets and dilators, you're more likely to pull down and have sufficient force there. And then what's nice about having the loop in place is very echogenic. So I'm really aiming kind of for the left atrial appendage being a little bit more anterior. Obviously, I don't want to be too posterior in terms of the challenges for ablation and also for appendage closure. And then I pull down the wire to have an inverted U. So I'm still not engaged in the fossa. I can still clock and counterclock the sheet to find the right position. And once I find the right position, I can pull back and get ready to puncture. And here we just happen to go across into the left atrium without actually having the RF. And then once that's across, we're going to go ahead and advance our now again, you could do all in one and just use your ablation sheath, or you can do it in two steps. But then we're flossing the septum just to kind of create an opening there to allow you to move the ice. And now I'm exchanging it for a deflectable sheath. This is the ferrodrive sheath to make a larger hole. And then I'm going to probe with the ice catheter to cross. So again, you see on my hands, it's just me and no friends in the lab and just two sheets there. And now I'm manipulating that ice catheter very closely and slowly to get on ice near that wire. And once you get near the wire, most of the time you can cross pretty easily without fluoro. Occasionally, you may feel as though it's not going where you want it to go. So there it's not going through. So I'm just going to step on fluoroscopy to see where my ice catheter is in relation to the wire. I'm actually right there, and I just advance and I'm in the left atrium. And once you get experience with imaging with ice, you can get the views analogous to the T views very quickly. So this is in real time. The first view I see the mitral valve. So remember, if you see the mitral valve and you see an appendage that's like the T90 equivalent, if you see an aortic valve in the appendage, that's a 45 equivalent. And if you see a PA in the appendage, that's a 135 equivalent, as close as we can get to using a 2D ice catheter. So here you see the mitral. I'm going to advance the catheter a little bit and adjust and clock and counterclock and maybe go a little bit rightward to try to get a nice view. And again, I'm excluding for thrombus. Now, in reality, if my suspicion for thrombus was high, I should have done pre-screening or looked at it from the pulmonary artery to verify. But again, this patient, you can see, has a fairly decent sized appendage, but I'm evaluating this for thrombus, and then also we'll do some measurements. And this measures out to be almost about 30 millimeters. And this is, again, a small patient with a small BMI, short stature, yet with a fairly large appendage for her size, which is fairly consistent with what we see in our Asian population, not very dissimilar from what we see when we go to Asia to do these cases. So immediately after that view, I'm going to counterclock to see the aortic valve. And once I see the aortic valve, apply a little bit of rightward tilt, and you'll see counterclocking rightward tilt, and you'll see the appendage open up, giving you what we would consider a low angle view. Okay, so here we're going to be analogous to a TE 45-degree view. And then we can do the measurements here. And again, you see it's very fine movements. I'm almost using two hands. But then, within as long as time it would take my TEE doc to get this view, you can do it once you get really skilled and comfortable fairly quickly. So now you have this low angle view. Again, I can verify there's no thrombus. We'll measure here again, and this is going to be closer to 30 again. from the same measurement. Again, and you see, I actually have a joystick that I'm using to do the measurements myself. So I really don't have friends in the lab, and is really just as single opera as you can get. And then after this view, the third view I want to get is a high angle view. So I'll rotate and clock the ice catheter to where I see the right pulmonary veins and deflect posteriorly, and the catheter will move down. Okay. And then you'll see the PA, which is coming straight down. You see the catheter's down, but it's looking up. So you see the PA, and then you see the appendage there. And now I'm measuring a more of a higher angle view because I'm seeing the PA. So there you can see the mitral edge there, and then you'll see the limbus, and you'll see the PA artery, similar to kind of a 110, 120, 130-degree view. And so this is basically my pre-imaging. This is probably one of the more important parts of the procedure, is making sure I understand the anatomy of what I'm dealing with in terms of the appendage. And after this, we're going to move straight forward directly to ablation. Okay. So on the next slide, if you'll forward to the next movie, we're going to just do a really quick 1 minute kind of sped up catheter ablation with mapping and ablate. So here we're using, again, you'll notice the patient is under deep sedation. So there are times when the patient may cough. We recognize that coughing may not even be the marker of the sedation, but we're not using a paralytic. We map a lot with the basket. This patient, I do believe we did veins and posterior wall. And we also kind of put the basket at the base of the appendage. But we're just going through. And one thing you notice, I don't have a coronary sinus catheter because we found, and there's data on this, right, that if we do the right-sided veins first, we tend to have a less vagal response and less need for one, high doses of atropine or vagolytics, and also the need for pacing. And so we typically give a low dose of glycopyrrolate, 0.2 versus the standard 0.4. But even glycopyrrolate, like atropine, can cause urinary retention. So we tend not to use atropine because we don't want them to wait 6 to 8 hours because they can't urinate after a successful, an hour and a half ablation or concomitant. So once the ablation is done, we have switched the sheath out. And this is just showing you the final kind of stages of deployment. We have the pigtail catheter in there. You see the anatomy. And what I want you to see is the actual angio. And I think it's important when you're doing ice-based that you really use your fluoroscopic images to kind of help you see. So you can see I'm injecting there, and doesn't really feel, but you realize how big the appendage is as I go up and down there. So now I'm going to do a moving angiogram because there's such a large appendage. And this is typically, and I brought up the fact this is an Asian patient, but this is consistently what we see in Asia. But this is an American, Japanese descent, and you can see the massive appendage. And at this point, there was no question. I'm cycling through the different views. And although I measured 30, this is an appendage where I want to use a larger size device. So we're going to pull out a 40-millimeter device. You can see even when I lay this out in this view, if I was to measure from the edge of the sheath down to the appendage, then I'm measuring something closer to 30 millimeters. And that being said, what I want here is a device that's going to fill out the appendage as much as possible and be long enough so that it can come out as proximal as possible and be stable. So here, again, I'm measuring post just to verify that there hasn't been any major changes. If I measure there, it's 28. If I go a little bit there, it's 22. And if I measure it out a little bit further, I'm getting closer to 30. So again, this kind of gives me a guide, but at the end, the angio influenced me. And I mean, I think most of the time when we see something in the low 30s, we're going to go to a 40 anyway. But when you see the size of that, you realize that you need to go big. And here I'm inserting the catheter. I have a deflectable sheath. That's a true steer. Now make the flexible, and I'm going to use the deflection. And this is why I think we've all transitioned when we can to deflectable to allow you to really angle and position the device. So now I have that flexible. It's still not in the 2 times the size of sheath size, but I'm being very meticulous here. I'm going to unsheath, and I'm going to start deflecting, trying to get it straight, and it falls into the posterior lobe. So I come back, reorient, undeflect, and take this orientation, and then start to keep it straight as it comes out. So you see the device deployed. I still don't love the fact that it doesn't seem fully opposed on angio. It looks like the distal aspect of the device is not fully open. As you'll see, this is the echo is live. I'm just repeating the cine here, just letting it play in a loop. And so what I do need to do a tug test and see if I can bring that kind of out and maybe see the angiographic tech test. The important thing to know is patients who are getting these procedures under deep sedation tend to have a higher rate of air embolism, and we can talk about it. But here's the tug here. So it's first going to be a gentle. I like to have contrast so I can kind of see where we're at. And there, the device came out, and it's a much better fit now. And we'll look in different views. But the important thing here is that these pressure patients are not under positive pressure ventilation. So we know there's a 6x increased risk of air embolism when you do these procedures with deep sedation. So you have to be prepared for that and have to understand where the risks are for air embolism when you do these procedures, and understand the LA pressure when it's low, that there can be air ingress in through the sheath. So these are all important things to think about as you're doing the procedure. So now you see the measurement there. That thing measured into like about 30 millimeters there, but I do like the position. And then we're going to quickly just do a sweep and check it in different views. So now our counterclock rotated, and we're almost done. And I'm getting a low angle view now, and I'll
Can I
open
ask
that
you a
up a little
question?
bit. Yeah, go ahead.
So in the transmitral view, I feel like you get to see the anterior lobe really well, and you measured at about 20 or 20, the smaller number than what we
30.
saw on
Oh,
angio. And I
yeah,
always wonder,
yeah,
it's because we don't get to see that posterior lobe well, right? So with the
yeah,
way this device is sitting, how would you assess that posterior lobe and leak into the posterior lobe on ice?
yeah.
Because I mean, there's so much data now,
Great points.
at least with ice-based new users with higher leak rates. So how would you advise our audience on that?
Well, I think the two things. One is when you do it with ice, you're always underestimating the size of the appendage because you're not always necessarily looking at it at the widest view. So I always tend to size bigger. So that's why I'm not sitting there focused on the ice measurement saying, is this 27 or 28? Doesn't really matter. I'm imagining it's probably going to be a little bit bigger than that. So that's number one. So having the right size device, and then also relying on your angio a little bit more. And sometimes we'll do a little more AP caudal to look at that mitral edge and see the posterior edge with a contrast injection. And that being said, the whole case we're using 15 or 20 cc's of contrast. We put contrast in the sheath, and then we inject it with a chaser of saline. So I think you relied a little bit more on contrast instead of trying to go floralist when you're doing this. And then recognizing, as you said, you don't see that posterior lobe as well. So you could clock the catheter even more and see that posterior lobe when you're in that transmitral view. But again, there is a skill set to learn to do this with ice, and you're gonna it's gonna be, either as good as, it's not gonna be better when you're doing 2D ice compared to 3D imaging. But another way to do this is using a volumetric ice catheter, which I think probably should be the future instead of 2D ice. Is having the ability to have that 3D 4D concept to really see and assess all the lobes.
It was a great case presentation. Any thoughts on your part, Dr. Horton?
Yeah, so I thought it was a fantastic case. The appendage closure part was when I first saw that angiogram, it was like, wow, that's a lot bigger than what the imaging had implied. I mean, if you looked at that, it was basically a whale tail. That if you looked at it from the superior or the cranialmost part to the caudalmost part, I mean, it probably was 55 millimeters across from one side to the other. So this is kind of one of those things where if you place the device posterior, you would have more compression, I think, because you'd have more depth, but you would also be more canted. You'd have a bigger shoulder. So that was not the preferable way to do it. This is basically you put it where it was. This is kind of one of those where I think if we had a 45, you probably would have pulled that out. This was a really big appendage. And I
And
think
there's
you
no
got all
question,
the
Rodney.
device you could. Yeah.
When they said what size, I'm like, give me the biggest one you have. It wasn't even like, what else is there? So, and I think what's interesting is, despite how big it looks at the ostium, the echo didn't lie. The compression was still at 30. So it's just so big outside. And the worry is always, as Rodney said, if you don't fill that volume, there's a chance these devices can potentially shift, especially when they're that big. So you want to reach the back wall if you can. So at least there's something engaging it on both ends. So I think that's a very good point, Rodney.
Yeah, and this is kind of one of those things
Question
where
about
the real answer is going to be at the follow-up imaging. What did it do? So was it doing acutely? That's one thing, but what does it do if you're doing an imaging study at 6 weeks, like some people do, or at 3 months, as some people do? it kind of, what does it do? Did it migrate distally and become a little canted, or did it sit exactly where it is? And that's kind of one of those things where I think the next generation of watchmen is going to have a little bit different performance characteristic, hopefully favorably with regard to that. And the 40 tends to act a little bit more like the newer generation Watchman device. So hopefully it will not migrate at all. If it does, I would sort of look at it and say, well, what else are you going to do? I mean, you could always go back and do a secondary closure, but this is the biggest we had. If we did have a 45, we probably would have used it, but we don't have it.
Yeah.
All right, we're coming near the end of the session. Devi, do you have any final thoughts you want to contribute?
No, I was going to say, Shephal makes this look very easy. There is a learning curve to ICE in the left atrium. I think we have seen the ICE adoption go up with the concomitant workflow going up. So I think my one thing about concomitant cases, especially with ICE guided cases, is that you want to be proficient in both before you embark on doing concomitant cases with ICE. And otherwise, having that second operator to help guide you is not a bad idea, to have a good workflow for both, and then learn the ICE workflow separate. But great case, Shephal.
One other comment, and is if you actually sort of tease down to exactly the technique that Shafe used to deploy it, he basically put it into a ball and then he advanced it into a bigger than normal ball and then sort of laid it exactly in that anterior lobe and slowly unsheathed to let it sort of lay itself out. And that helped to keep it from folding or doing something that was kind of unexpected. And these are the things that he does kind of intuitively, but if you're trying to teach somebody about it, you kind of have to spell it out. This is what he actually did.
All right. Well, thank you very much to everyone for participating. It's with great gratitude for the excellent case from Dr. Doshi, as well as the insight that we heard from Dr. Nair and Dr. Horton. Our U.S. Focus Day 1 will continue, so please stay with us.